order Dehenna Davison to move the motion.
Thank you, Mr Mundell, and it's a pleasure to serve under your chairmanship as ever. Now, let me start by stating the blooming obvious. Migraine is not just a headache. Migraine is a complex neurological spectrum condition for which headache is just one possible symptom. So this is a very strong early message to anyone suggesting you can cure a migraine attack with a couple of paracetamol. It's time to learn, and it is time to be better. Listen to this debate today. Listen to the testimonies of those living with this debilitating condition, and help us together overcome the stigma surrounding migraine, stigma which for centuries has acted as a barrier to those suffering from accessing quality treatment. Now, before I get into the full swing of things, I just want to express my gratitude to the House authorities for organising a survey that's seen over 500 migraine patients responding. I'm grateful to each and every one of them, and also to others who've reached out to me separately to share their experiences. Now, some of those testimonies have been eye-opening, some have been quite harrowing, and I'll endeavour to include as many of those as I can in this speech. And as ever, my thanks go to the National Migraine Centre and the Migraine Trust, not only for their support for today's debate, but their round-the-clock work to support people living with migraine. Now, you can't have a Westminster Hall debate without a bit of a history lesson at the beginning. So I did a bit of a dig through the history of migraine and found that some of the earliest known references to migraine date back thousands of years to ancient Egyptian times. And then the father of medicine, Hippocrates, was the first to document clinical observations about migraine in about 400 BC. Classifications of headache were first outlined by Aretaeus of Cappadocia in the 1st century AD, with his category of heterocrania displaying many similar symptoms to migraine. Galen wrote of severe pain affecting almost half the head in the 2nd century. It was the Iranian physician Razi who devoted an entire chapter of his book to the symptoms and treatment of migraine in the 9th century. Then in the 17th century, Thomas Willis published his theory that megrim was owing to the dilation of blood vessels within the head. Now, throughout those years, key figures are reported to have experienced migraine. Leaders like Julius Caesar, Napoleon Bonaparte, both Ulysses S. Grant and Robert Ely, Woodrow Wilson and John F. Kennedy. Great thinkers like Sigmund Freud, Friedrich Nietzsche, Charles Darwin, artists like Van Gogh, writers like Virginia Woolf, actresses like Elizabeth Taylor, actors like Hugh Jackman, Gwyneth Paltrow. There's even strong speculation that the trippy nature of Alice in Wonderland was inspired by Lewis Carroll's own attacks, migraine attacks with aura. In his own diaries back in 1885, Carroll talks of the odd optical affection of seeing moving fortifications followed by a headache. And his works actually led to the term Alice in Wonderland syndrome being coined to describe, and I quote, certain hallucinations peculiar to migraine. Now, in Carroll's diaries of 1956, he records a trip to see William Bowman, one of the top ophthalmologists of his time, to discuss the visual disturbances in his right eye, but Bowman was unable to formally diagnose this. Now, perhaps this was because it wasn't actually until the 1870s that visual manifestations of migraine began to gain more widespread recognition amongst medical professionals. Though with migraine twice as likely to affect women than men, of course, in that period, it was believed that we weak women merely had hysteria and fragility of the mind, rather than the ambitious men who only got migraine because of how hard they were working. I think women being taken seriously in healthcare is a bit of a pet peeve of mine. And so whilst I did greatly welcome the Women's Health Strategy, I was a little disappointed not to see migraine more formally mentioned, and perhaps the Minister will discuss that with me separately. So we talk of the 1870s, some 150 years ago, and we might naively assume that in that time, the magnificence of medical innovation has created cures and solutions, meaning people no longer suffer with the terrible symptoms of migraine. It was actually back in 1954 that the then Minister of Health told those affected by migraine to cheer up. There's a good deal of work going on, mostly under the Medical Research Council, which led to a response in 1960 by John Rankin, then the Honourable Member for Glasgow Govan, where he states, for 6 years, and long before that time, the good work, so we are informed, has been proceeding, yet nothing appears to be happening. We're now over 60 years later, and despite migraine affecting roughly 10,000 people in every constituency in the UK, a Hansard search informs me there's been no full debate on migraine here in Parliament since the 1960s. I will give way.
I congratulate you on a powerful and extremely well-informed speech. One of those 10,000 in the Kettering constituency is my constituent Lisa, who has written to me to say I spend most of my weeks either with a migraine or with the after effects, which include complete exhaustion and can last for 2 or 3 days. I have medication which doesn't always work. I get facial paralysis and will often have slurred speech, light sensitivity, nausea, dizziness, along with immense pain and pressure in my head. It's an awful existence, Lisa says. And she says, and I want to pass on to my honourable friend, I am so glad to know that it's being debated in Parliament today.
Well, I'm very grateful to my honourable friend for that and for passing on Lisa's remarks, though Lisa is one of millions in the country living with this condition and experiencing the debilitating effects. And hopefully, following today's debate, we can see improved access to treatment. So you can pass that back on to your constituent Lisa, to his constituent Lisa. Now, as I said, 10,000 people in every constituency, but no debates here in Parliament since the 1960s. But a special mention to my noble friend Lord Lonsborough for raising a question on migraine in the other place in October last year, rightly arguing that this invisible disability deserves much greater priority and resourcing across the NHS. 60 years since the last parliamentary debate, and for those suffering the crippling effects of migraine alone, they may well feel that even now, after all this time, little progress has been made. But I'm actually here to be optimistic, because new treatments like CGRP blockers are proving highly effective for many migraine patients in helping to reduce the severity, longevity and frequency of migraine attacks. For many taking CGRP blockers, they're often called a lifeline. One patient responded to our survey saying that CGRP injections have, quote, virtually eradicated my migraines. But whilst new effective treatments are being developed, they are not easy to access through the NHS. So across today's debate, I'll outline the key difficulties being faced by patients at each stage of the migraine journey, and we'll outline some possible solutions to improving access to treatments and, ultimately, to improving the lives of migraine patients, something that I think all of us here can agree is very much beyond politics. So let's start with the basics and discuss what it is like to live with migraine. Now, we had an example from Lisa, my honourable friend's constituent. When experiencing a migraine attack, common symptoms can include, of course, a severe headache, nausea and or vomiting, visual disturbance, blurry vision, seeing spots of light or zigzag lines, sensitivity to light and sound, an inability to concentrate and brain fog, difficulties forming words, not always helpful in this place, and fatigue. And interestingly, I had experienced migraine for years before even I recognised some of the symptoms were linked to it. I can recall sitting at home reading Managing Your Migraine by Dr. Casey Munro last autumn with a coloured pen in hand, underlining all of the symptoms that I experience when I get a migraine attack, and there were 8 different symptoms. A severe attack can leave sufferers bedbound, in agony, curtains closed, cowering in the darkness, unable to eat, unable to think clearly, and utterly miserable. They can be completely debilitating, and I've experienced my fair share of those. But I'm not the only honourable member who lives with migraine. The honourable member for Caerphilly isn't able to attend today, but asked me to read his testimony in his absence. He said, "I've suffered from migraine since I was a young man. It used to be extremely debilitating, but in recent years, I've been able to minimise significantly the severity and frequency of attacks. There are so many different causes and triggers of migraine. For me, it's stress-related. Manage my stress, and I can usually manage my migraine." Similarly, the honourable member for Banff and Buchan said, "I first experienced migraine in my early teenage years when I regularly had to be excused from school. I remember being particularly distressed at the disorientation and confusion, as well as the extreme headache and nausea, of course. Migraines have become no less debilitating as I've grown into adulthood, but they have become less frequent, and I generally know what to expect when symptoms start and what medication to take. Like my own father before me, I now watch my own 12-year-old son experiencing his first migraines and the confusion it brings. As much as I can empathise with my son, I'm only too aware of how little I can do to relieve his distress." Now, the frequency of migraine attacks can vary. Some people will experience just a small number of attacks over a lifetime, some 1 or 2 a month, but for others, migraine can become chronic, meaning that headache is present on over 15 days per month, with at least 8 of those having other migraine symptoms. And it's this condition that I live with, as do around 1 million other people in the UK. For me, it means that I have a headache all day, every single day. Whilst they vary in severity, they're nonetheless draining, particularly on the many days when they are coupled with other migraine symptoms. Recently, I spoke to Molly Campbell, a brilliant young woman who, like me, lives with chronic migraine. And I think her journey really helps to outline some of the difficulties that patients face in accessing treatment. Now, she remembers vividly her first attack. In her words, "On a normal day, I woke up in agonising pain in my eye, eyebrow and head. When I say pain, I mean torturous and excruciating pain, the kind that makes you roll around on the floor sobbing in agony. Molly sought help from her GP, but it took months, several misdiagnoses, a number of unsuitable drugs prescribed, and eventually her paying to access a scan privately before she was eventually diagnosed with chronic migraine. And unfortunately, Molly's story is not uncommon. It can take patients months, if not years, to actually get a diagnosis. A commonly expressed sentiment is that GPs do not always take the condition of migraine seriously. One patient responded to our survey explaining they waited 5.5 years from first presenting to a doctor to them taking it seriously and investigating. Another said it took 19 years to be diagnosed with migraines. And another, doctors just don't seem to know or understand enough about it, and I've been fobbed off a lot. I will.
Way on that point, I was contacted by a constituent who wishes to remain anonymous, who suffers from debilitating hormonal migraines. And what she is frustrated by is a sort of lack of general awareness among medical professionals, particularly GPs, about what specific treatment and medication those who suffer from this type of migraine need. So does she agree with me that in making progress in addressing the condition, we need to, among medical professionals, ensure there is greater knowledge about what specific treatments those who are suffering from perimenopausal and menopausal migraines need?
Well, I completely agree with my honourable friend, and he'll be interested in a paragraph very shortly that I'll be reading out, which addresses his very point. Now, another testimony said, I've suffered migraines for approximately 4 to 7 years, but I never went to the doctors until recently through fear of being dismissed. Some believe this is because GPs across the board just don't know enough about migraine. One GP said to the Migraine Trust, in medical school, neurology is a very small part. Unless you have specifically chosen to do neurology, you'll not have any formal training. GP training on migraine and headache disorder is patchy at best, and often relies on local champions spearheading this, rather than any more formalised structure. So on this, our clear ask for the Minister is to ensure that there is improved training on headache and migraine as part of medical training for GPs to ensure that this early diagnosis is possible. Now, for those who do get a diagnosis, seeing neurologists or headache specialists is a crucial step in helping with ongoing management, not least because specialist treatments cannot be accessed through primary care, and I'll return to this point shortly. On waiting lists for specialists, experiences do vary, but the broader picture is not as positive as it could be. 2 patients outlined that after many years of waiting for a diagnosis, it took a further 4 years from that point until they saw neurologists. One said, I waited 5 months to receive an appointment letter, then another 5 months until the actual appointment date. Another waited 15 months to see a neurologist, who then referred me to a specialist. I've been waiting for 7 months for that with no appointment yet. Even when eventually under the care of a specialist, some outlined the continuity of care was not there. One patient said, I was prescribed a treatment to try and was discharged, and then I had to be re-referred to try an alternative when the first option didn't work. Recent analysis from the Migraine Trust found that it takes on average 29 weeks to access a neurologist or headache specialist, which has actually doubled from 15 weeks in 2021. And even then, neurologists themselves may specialise in other conditions like stroke and Parkinson's rather than headache and migraine. Part of the issue, as well, is a lack of neurologists and headache specialists around the country. The UK has around 1.1 full-time equivalent neurologists per 100,000 people versus 4 per 100,000 in France and Germany. Regional variations also mean there's a postcode lottery with major disparities between waiting lists from trust to trust. So here, our key plea to the Minister is to ensure that more specialists are trained to help plug the gaps in neurology and headache specialists, and ultimately to speed up access to treatment. Now, once a diagnosis is in place, the obvious next step is treatment. Often GPs will prescribe acute medications such as triptans to help manage attacks when they occur. For those suffering more frequent migraine attacks, preventative medications can also be prescribed. However, many of these were not designed specifically for migraine, such as topiramate, an epilepsy drug, amitriptyline, an antidepressant, or candesartan for the treatment of high blood pressure. While some people do report an improvement in the severity and frequency of their migraine attacks, many do not, and can in fact experience negative side effects from these medications. Nevertheless, there are now treatments designed specifically for migraine, such as CGRP blockers, as already referenced. And there are many different kinds, wafers that dissolve on the tongue, injections, infusions. However, NICE guidelines are, for many, getting in the way of early treatment. Take one CGRP blocker, I always pronounce this one wrong, Erenumab, I believe is correct, as an example. Now, a 2021 study in the Journal of Clinical Medicine by Mariah Ritchie et al. Found that as a treatment for the prevention of migraine, Erenumab successfully reduces the mean number of monthly migraine days and the acute medication used per month in 96% of cases. A real success story. However, NICE recommendations state the drug is, and I quote, recommended as an option for preventing migraine in adults only if they have 4 or more migraine days a month and at least 3 preventative drug treatments have failed. So let's just take a second to understand that for what it is. If you're struggling with migraine, you must try 3 drugs that are not designed for migraine, usually for at least 3 months each. And if they're unsuccessful, then you may be able to access a drug that is specifically designed to prevent migraine attacks. It makes little sense to me, and it can delay patients from accessing successful treatments for months, if not years. As one survey respondent said, getting treatment has been difficult. To access the latest treatments, you have to fail so many preventatives. Now, the American Headache Society and migraine expert Professor Peter Goadsby have suggested that CGRP blockers should be available as a first-line therapy, not as a last resort. And we really do support this call, and so I'd ask that the Minister request that those NICE guidelines are updated to allow specialised treatments like CGRP blockers to be accessible first, providing earlier, much-needed relief for migraine patients. And similarly, despite approval by NICE for many CGRP blockers, in reality, there is a postcode lottery for whether individual NHS trusts even allow access to them at all. One respondent said, once help is found, though, it can be difficult to access it as it depends on which area you live in. Another said, my NHS trust only allows a trial of one of the anti-CGRP drugs, and if it doesn't work, you're not allowed to try another as it's not funded. Now, a Migraine Trust Freedom of Information request, which I found quite shocking, found that, in fact, only 29% of trusts in England allow access to CGRP medications. So here we make yet another ask of the Minister, and that's for the postcode lottery in access to CGRP medications to be addressed and fixed, perhaps by having fresh guidance issued by NICE and a dedicated push from the Department of Health and Social Care for trusts to allow more access to these life-changing medications. Another key change, which could help those living with migraine access positive treatment sooner, would be allowing treatments like CGRP medication to be prescribed by primary care practitioners. I've spoken of some of the success of CGRP blockers, and yet at present they can only be prescribed by specialists such as neurologists who, as we've discussed, can have extensive waiting lists just to be seen. And even then, right now, need to demonstrate that other treatments have been ineffective. If specialist drugs could be prescribed in primary care as a first resort, this could severely reduce the impact of chronic migraine on patients. Pilot work in Scotland has seen community pharmacy playing a greater role in prevention, prescriptions and management of migraine. So a further ask for the Minister, if he'll forgive me, is to request a review of CGRP blockers and other new treatment options to allow them to be prescribed in primary care. I will.
Thank her for giving way and congratulate her on securing the debate. Just on the issue of trying to make the blockers more widely available, would you agree with me that in addition to the number of requests she has put to the Minister, that perhaps some discussion and consultation with the devolved institutions in order that people right across the United Kingdom can avail of the same?
I would completely agree with my honourable friend. As I've said, migraine is a condition that doesn't discriminate, and with roughly 1 in 7 people in the world living with migraine, of course, this is as relevant in the devolved authorities as it is anywhere else, and we want to make sure that migraine patients across the whole UK have access to the best possible treatment. Now, for those who can't access CGRP blockers or alternative treatments through their local NHS trust, or sometimes for those who simply can't bear the extensive waiting list to see specialists, the drugs bought privately can be incredibly expensive. Rimegepant, for example, is around £270 per month when taken as a preventative. Botox injections for migraine are around £700 every 12 weeks, and Vyepti infusions are around £600 every 12 weeks. And that doesn't include the cost of seeing specialists and actually having the prescriptions written, which, of course, is an additional fee. Now, for those on low incomes, these options are completely inaccessible without NHS treatment. And yet some are unable to access them regardless because of decisions by their local NHS trust. One survey respondent said, I had to spend £8,000 on CGRP treatment privately before moving to a hospital who would fund me under the NHS. Nobody should be priced out of quality healthcare, particularly when that healthcare can be truly life-changing. In all, I've outlined so far a number of tangible steps that could be taken to have a real positive impact on those living with migraine. But let's return to Molly's story, because sadly, Molly's experience is an example of how the current system doesn't always work for patients. In her words, 4.5 years later, there is not 1 second of any day in which I'm not in pain. My pain's an average of 7 out of 10 a day, and it soars up to 10 out of 10 at least 10 times a day. When it reaches these levels on a daily basis, every single day, you simply cannot live life normally anymore. I can no longer work, see my friends, or do any of the hobbies that I used to enjoy. Every single thing that brings me pleasure is now impossible for me. For those living with severe chronic migraine, the huge detrimental impact on day-to-day life cannot be understated. I've reached a point where I get anxious making future plans, either for work or with family and friends, for fear that a severe attack may mean that I have to cancel last minute. And with attacks seemingly getting more and more frequent, it feels increasingly like cancellation is an inevitability. And this may sound really silly to some, but it's a really kind of human example for me, which is I've been a lifelong Swiftie, and I managed to achieve the holy grail of getting Taylor Swift tickets for the Eras tour. And I am petrified that on the day a migraine attack might hit and take away my opportunity to see her live, because I would be devastated. Now, some might say that's a silly example, but it's one of those things that is on my mind. And it's the sort of thing that, if you're living healthily, you don't even have to have those sort of considerations when making future plans. And many survey respondents reported similar concerns. One said, migraine has impacted every job, social occasion, and holiday over the last 15 years. It's caused me countless days of agony. Migraine is a curse I wouldn't wish on my worst enemy. Another said, I can't make plans with people due to migraines making me cancel them last minute. I missed an expensive, once-in-a-lifetime concert opportunity that I'd been waiting 12 years for as I had a migraine that day. I also had to leave a friend's funeral early and not attend his wake due to a 5-day migraine. One said, I've missed many family gatherings, New Year's, anniversaries, etc. I've also missed events that I'd purchased tickets to as I've been too unwell, losing out on both money and experiences. And another said, I gave up working 14 years ago, stopped socialising, and even dread going on holiday. And travel was the thing that I always most looked forward to. I received an email yesterday from June about her daughter. She's 35, and her migraine attacks are so severe that, in June's words, she can no longer look after her children. At this moment in time, she cannot complete a simple jigsaw with her 2-year-old daughter. This is my daughter who gained a first in her degree. She's upset about missing out on so much of her children's lives. They're aged 5 and 2. Now, I raise these examples to show that the impact of migraine has more than just a trivial impact on the individual suffering. It has a real impact on them, and also on their loved ones and wider circle. Many also spoke of the impacts of migraine on their working life. Indeed, Molly had just embarked on her dream internship when migraine hit. So she was unable to complete that internship and has struggled to work since. She's not alone. Many here will know that I gave up my ministerial role as migraine meant that I couldn't keep up with the additional demands of government. Now, research by the Migraine Trust found that 29% of people with migraine had to move from full-time to part-time work, and 25% had left a job altogether. One survey respondent said, I've been at risk of losing my job in the past due to having to take time off for migraines. And another said, I recently lost my job due to the number of migraine-related absences I had. While some workplaces do make adjustments, such as allowing flexible working, I will give way.
Thank you, and thank you for securing this debate today. But in light of what you've just said, many people who suffer from migraine lose their job and have difficulty accessing even the likes of PIP, because it is so debilitating whenever it happens, and it's so unpredictable, and their life can become so awkward to just not do things normally, and they have difficulty accessing PIP because of it.
Well, I'd agree with him. In severe cases, this is absolutely a disability. Migraine is a disability. It ruins lives. And I do think there's a separate discussion to have with the DWP. I don't want to put all the pressure on the Department for Health with the DWP about how they actually address chronic migraine and intractable migraine when making their assessments. And I thank him for raising that really important point, which did come through from a number of our survey respondents as well. Now, whilst some workplaces do make adjustments, such as allowing flexible working, there are also reports of workplaces not making suitable adjustments. One respondent said there is a complete lack of understanding that chronic migraine is a disability. and employers are not willing to make allowances for the condition in the way they do with other disabilities. The Migraine Trust shockingly found that 56% of migraine patients said their workplace had not made reasonable adjustments. And that's why the Migraine Trust has launched their Workplace Pledge this week to encourage employers to make small, often very low-cost adjustments, which can make a huge difference for their staff with migraine. And remember, with 1 in 7 people living with migraine, there's a good chance that even if you don't, at least one of your colleagues probably does. But the impact of migraine on the workplace is not just confined to individuals dealing with the stress of potentially losing a job and income. There's a wider impact on the economy too. The Work Foundation has found that migraine causes between 28 and 43 million lost work days per year in the UK, at a cost of around £4.4 billion. Now, when you add the cost of this absenteeism to the cost of presenteeism, that is, showing up, putting on a brave face, but not being able to function in the way that you normally would, the Migraine Trust estimates the total cost is closer to £9 billion. Now, we talk often about the need to improve productivity here in the UK, so surely helping those living with migraine access quicker treatment and better treatment so they're able to work and fire on all cylinders would be a great step forward, especially when coupled with the fact that, according to the Journal of Health Economics and Outcomes Research, the excess fiscal costs of the government of one person living with migraine are £19,823. That's a cost for one person when there are 10 million in the UK battling this illness. Now, giving up work for health reasons is not a choice that anyone makes lightly. And for many, as well as a financial cost, there can be a significant cost to people's mental health. Research by the Migraine Trust found that 78% of those living with migraine said it had a negative impact on their mental health, and 65% reported experiencing anxiety as a result of it. Missing work, cancelling on friends, missing out on social experiences you've been looking forward to and paid for, feeling like you're a burden on your family, people not believing you, waiting months, if not years, just to see a specialist, having the hope of trying another preventative that might work, only to have it shattered when it's another one that doesn't. All the while living with excruciating pain, losing friends, losing relationships, and feeling like you're losing your mind. For some people, like Molly, the darkness takes over entirely. She said, "Deep inside, I still have that same passion for life that all people in their 20s do. I want nothing more than to go outside and live my life, but this condition has me trapped in my own living room. My pain is now so severe, it's impacted on my mental health so intensely that I contemplate suicide every single day of my life and have almost succeeded at times, simply because I want the physical pain to end." Now, we are here today to help people like Molly. We have a responsibility to help people like Molly and the millions of others suffering through migraine who need a lifeline. By improving access to treatments, we can give them that lifeline. And I hope the Minister will agree to meet me and the two brilliant charities represented here today to discuss further how we can do just that together.
I'd ask members who wish to be called in the debate to Bob. And I now put the question. The question is that the House has considered access to migraine treatment. And I call Sir Gavin Williamson.
Thank you, Mr. Mandel. It's a great pleasure to serve under your chairmanship. And if I can start off by congratulating my honourable friend in securing this debate. And it's hard to imagine that this hasn't been discussed in Parliament for such a long period of time, especially as she so brilliantly articulated the wide impact it has on so many people in every one of our constituencies. That statistic of 1 in 7 people suffering from migraine, and with over 1 million people suffering from chronic migraine, the impact that this has on so many people's lives, so many families, is so widespread. I'm very fortunate. I'm not one of those 1 in 7, but I have the experience of living with someone who suffers from chronic migraine. And actually, when you do not suffer from migraine, you don't understand how debilitating migraine can be. You can't comprehend how it can take over someone's lives, stop them from doing the things that they most want to do, that they get pleasure from, that they live for. And then that migraine seizes them. They just can't do anything. They have to lie in that darkened room and actually not function in the way that we expect and hope for people to be able to function. And it is concerning and it is saddening when you do actually look at some of the statistics. And my honourable friend touched upon the fact that actually, so many people, according to the Migraine Trust, 29% of respondents, had actually had to move from full-time work to part-time work. This isn't just an impact in terms of what they do. It has an impact on their whole family. It has an impact in terms of what they can expect from lives, their ambitions for the future. This is something that can change the course of their lives. And it's also particularly concerning that 43% of those surveyed felt that their workplace didn't believe them when they came in and said that they had had a migraine. And as my honourable friend touched upon, the sense of, a bad headache. And this isn't what people are having to live with. This isn't what people are experiencing. It is something that seizes them totally and utterly. And we do need to be more open about the wider impact that that is having on so many. And the fact that 34% are feeling as if they're discriminated at work because of this, that is just so wrong. So I hope by talking about it, by highlighting the impact that it has on so many, actually we can improve the understanding that people have, not just the minister, not just his department, but actually workplaces right across the country, so that they're able to adapt and work with those people that suffer to make sure that they are able to give their very best all the time while dealing with something that we wouldn't wish anyone to have to deal with. And it does have a much wider impact. That loss in terms of those days worked, that impact it has on those businesses, that impact it has on those individuals, means it's something that we've got to start thinking about differently. And that is not just in terms of our hospitals, but as has been touched upon, also in terms of our general practice and also in terms of pharmacy as well. Because I think we've got to look at doing and tackling this in a different way. If we were looking at many other more visible diseases or visible conditions that people suffered from, this would be something that actually the government wouldn't be just spending I think it's £150 million on a year, but actually looking at investing so much more, not just in terms of the treatment, but also in terms of the research to be able to deal with this. And sadly, it is one of those conditions that actually there isn't one single answer that can just be rolled out, and of course it answers the problem and the deals with the condition that every single person suffers. We're seeing in this country more and more people turning to A&E in order to be able to get treated for migraine. This isn't actually the best place for them to be treated. It's not good for the hospitals, and it's not actually good for the individual. We've probably all seen in this room about how actually making sure that we get the right primary care and we put the right level of support for people so that they're able to prevent migraine as much as possible. Because, of course, when migraine comes on, it is so much more difficult to treat as soon as it has set in. And we do see understaffing in this country. We have 1.1 neurologists per 100,000 people in the United Kingdom, compared to 4 per 100,000 in France and Germany. And we see that actually so few GPs have a true specialist knowledge that is really needed to be able to sit down with their patients, to be able to talk through this and have a proper understanding of the type and range of treatments that is best suited for that individual. Now, of course, the Minister, I'm sure, will talk about how all GPs have in their basic training a coverage of neurological conditions, including migraine. But with the prevalence of migraine in society, we really need to be looking at not just general practitioners having a bit of general knowledge about it, but certainly in the larger practices where there is more specialist knowledge that can actually sit within that practice. So that actually we can be getting those individuals that are unfortunate enough to suffer from migraine the specialist advice and the specialist treatment with the specialist knowledge that they need. Again, because we are so short of neurologists across the NHS, making sure that that burden is lifted away from our hospitals as well. But I would actually put in a particular plea, as I touched upon, in terms of pharmacies as well. Of course, it isn't always that easy to be able to see your doctor on that day when you know a migraine is starting to emerge, or those indicators that you are going to be hit with a migraine start to show themselves. This is why it's so important to make sure that that support and that help is most widely available. And I would urge the Minister to use his characteristic, imaginative, thoughtful and revolutionary style to go back to his department and actually encourage them to be a little bit more bold, a little bit more radical in their thinking, a little bit more action this day as against another report, Minister. And I would urge you to do that because there are many things that can actually make a difference to people's lives very quickly. And one of those things is about making sure we make better use of our pharmacies, making sure that we lift pressure off a wider NHS, but also making sure that we get that better training in our GPs so those larger practices have that specialist knowledge. If I could just finish off with a final plea. My honourable friend mentions about CGRP blockers. Again, we're all aware there is not a silver bullet to this problem, but it is one of those things that I think gives so many sufferers just a little bit of hope that there is something that can actually help them. It is awful that so many parts of the country, people just can't get access to this. They're not in a position to be able to get the help that they so desperately need. I would really urge my honourable friend to go away, go back to his department, look at this very, very closely, along with a number of the other actions, because you could do something, my honourable friend could do something that could be transformative for the lives of many hundreds of thousands of people and lift the misery that they have to live with so often and far too often in their lives.
Caroline Noakes.
Thank you, Mr Mundell, and I would like to add my congratulations to my honourable friend for having secured this important debate. I'm going to be a little bit cheeky. It's always a privilege and a delight to follow my honourable friend, right honourable friend, the member for South Staffordshire, who I have absolutely no memory when he was Chief Whip of advocating radical and bold behaviour from the dispatch box. In fact, quite the opposite. But look, this is a really serious subject, and I was very privileged in November last year to host an event for the Migraine Trust. My honourable friend for Bishop Auckland has done the most incredible job setting out not only the history of migraine, explaining in some incredible detail the challenges that sufferers face. And I had, when I agreed to host an event for the Migraine Trust, I thought I understood migraine. I thought I recognised the symptoms, the impacts, how sufferers really did endure the most horrible, horrible events in their lives through migraine. And that was right up until I spoke to some of the sufferers who were there that evening, because we focus very much on the 1 in 7 people, the 10,000 in each one of our constituencies that suffers from migraine. But I was particularly struck by those chronic migraine sufferers who were there that evening, those who were triggered endlessly by such a radical thing as light, who were having to stand there that evening in a room with dark glasses on, with earplugs to be avoiding noise as well, who were telling me the foods and the drinks that they avoided absolutely rigorously because they could identify each and individual trigger that would perhaps set them off to a period where they would have literally a migraine every single day for days and days on end. And it was very eye-opening to me because I thought I understood migraine. I thought I'd understood migraine since the first attack I had when I was about 10 years old. And we shouldn't focus exclusively on our own experiences. But I remember that to this day. And I blame my father. I blame my father for many things. But he took me to McDonald's as a 10-year-old. And the blue light that they had in that McDonald's in the early 1980s, and I can remember where it was in Southend, triggered a migraine in me that day that I didn't understand what was happening to me. And that's the challenge for children, isn't it? They don't understand. They can't process that this is something that if they lie down quietly and they take their medications, that they may get through it. And it impacts their education. It impacts their entire childhood because they become, as my honourable friend detailed, they become anxious. They worry endlessly about when the next one will come. And of course, what we also know is that stress can trigger migraine. So the sheer act of worrying about the next migraine will in fact trigger it. And so that evening with the Migraine Trust, talking to these chronic migraine sufferers was incredibly eye-opening for me and made me absolutely determined to redouble my efforts to tackle the lack of knowledge and to tackle the stigma that surrounds migraine. And I was quite surprised. I only heard from one constituent ahead of this debate. And I just wanted to focus on her story because much of it has already been highlighted today. So she has suffered from migraines for 30 years. 30 years of her life in which she says that every single job she has had has been impacted by it. And every single employer has not understood that this is not just a headache, that this is something that is utterly debilitating, where she will not be able to attend work, she won't be able to function normally, and as a result, she's had extreme difficulties with her employer. And her ask of me is that I would advocate to the Minister, and I do so now, that we should perhaps looking at adding migraine to be considered as a disability, because, to be quite frank, it absolutely is. And she also talked at length about exactly the point my honourable friend highlighted about medications, and that the medications which, as we've heard, and there's no one silver bullet. Some will work for some people, some will work for others, but the process almost of trial and error of going through 3 months with a medication that you know is not working, but you have to go through those steps, jump through the hoops to make sure you can demonstrate that that hasn't worked before you can move on to the next stage of medication. And I just wanted to talk very briefly about the stigma and how some of us are too embarrassed and ashamed to talk about it. And I remember taking beta blockers for migraines when I was a minister. And let me tell you about the side effects of beta blockers and how impactful they are. Because when you're stood at the dispatch box, beta blockers will make you feel stupid. They make you feel slow and dull. And the one thing that everyone expects you to do at the dispatch box is to answer a question immediately, wittily, the facts tripping off your tongue instantly. And when taking beta blockers, I found that I simply couldn't do that. I would stand there and just feel kind of dull and detached and as if I wasn't really in the room. So I stopped taking them and resorted to a medication or type of medication that is hugely stigmatised, and that's Botox. Approved by NICE for migraine, and for me, incredibly effective, but incredibly expensive because I can't get that on the NHS. And I was frantically tapping on my phone. It wasn't me sending messages. I was using the calculator to work out how much I might have spent on Botox over the course of the last 15 or so years. And it appears to add up to a phenomenal £20,000 just to make sure that I can stand in this place and talk relatively coherently and at times making sense. Because, of course, it is the impacts like that. I can remember vividly being sat in the tea room and not being able to think of the right word. And I thought, well, it's fine. We all have had a little bit of brain fog when you get to my age. But it wasn't that. And it got worse and worse. And the longer I sat there, it wasn't just that I couldn't think of the right word. I couldn't think of any word. And then I found I was sat in the tea room for about half an hour silent because I couldn't actually speak. Now, as I made reference, my right honourable friend next to me is a former Chief Whip. He would have no doubt been absolutely delighted if I'd gone through entire spells of not being able to speak. I'm sure the current Chief Whip would also be very happy if I lost the power of speech. But it's absolutely terrifying and has a hugely profound impact on you. So I resort to expensive treatments that are socially stigmatised, and everybody assumes that it's vanity. I prefer to use the phrase, 2 birds, 1 stone. And the impact that has, it means that I can live my life, but it's not a choice that's available to very many people. And that's the stark reality. And as Monica would tell you, she wants the new CGRP medications to be more easily available. She wants them to be available in every NHS trust so that there isn't this postcode lottery. And most of all, she wants the stigma to be beaten down so that she never again has to explain to an employer what a migraine is, as opposed to just being a headache. I do think, and it was absolutely fascinating to me to hear the tales of the Honourable Member for Caerphilly and the Honourable Member for Banff and Buchan, who can't be here, and their experiences with migraine, but also the experience of watching your child suffer from it. Now, look, as I said, I blame my father for my migraines. My daughter blames me for hers. And there clearly is quite a significant genetic link to suffering. And I think that we need to have much more research and investigation into the condition more widely, but also some of the specifics that we've heard in this debate today. And I do think that we need to reflect that stress can be a phenomenal trigger of migraine, and therefore we need to be much more holistic in the way we approach it and think about the way we manage our lives. If my honourable friend, the member for Chatham and Aylesford, was here, she would undoubtedly be making a pitch for there to be a new government department for well-being. And this could sit very firmly in that, because actually if we address some of the mental health challenges around stress, we can also address some of the challenges of migraine. I do not pretend that we can address all of them. There clearly is a very crucial and important role for medication, which needs to be much more widely available. I finish just with the thought, look, this is a complex, difficult subject. There is no silver bullet, but what we do require in this place is a real drive from the department to make sure that they're thinking about including it in all of their health strategies. I stand here as the chair of the Women and Equalities Select Committee and was really struck by the fact that more than twice as many women are likely to suffer from migraine than men. If you look around this chamber today, as ever, it would appear that it is a male problem. But when we look at things like the Women's Health Strategy, it's crucially important, I welcome it, but we cannot allow the Women's Health Strategy to be about some of the stereotypical women's conditions. We also have to have a thread that weaves through the fact that in almost every health condition, women are underrepresented in research and underrepresented in the way the condition is treated. And too often, and my honourable friend referenced it, we are deemed as being hysterical as opposed to actually being ill. And my final comment to the DHSC on that is, please can we make sure that the impetus on the women's health strategy is maintained and kept up, and that we don't allow it to just become about reproductive health. It has to include the whole of women's health to make sure that we are being treated fairly.
Opposite SNP spokesperson Owen Thompson.
Thank you very much, Mr Mundell, and I commend the Honourable Lady for Bishop Auckland on not just bringing this debate, but all the work that she has personally done in raising awareness and sort of the campaigning for those who suffer with migraine. I mean, I think I, like many, spent a long time not realising that I was getting migraines. I'm very lucky, I don't get migraine very often, and I know that I'm very fortunate in that sense. But when I do, I'm absolutely floored. I tend to get clusters due to stress, as others have said. So I'm very fortunate that it doesn't happen very often, but it took me many, many years to realise that that's actually what was happening. And I was very, very lucky that I had a GP who actually kind of was able to understand what I was saying to them. So I now know what my triggers are, I now know what I need to do when it happens. Doesn't make it any easier to deal with, but at least I know what needs to happen. But I think this is a common story where we know, many of us know what migraine is, but the fact that we've not had a debate about it in this place for so long, when so many, even in this room alone, are talking about our own personal experiences, says that even within here, it's not something we want to talk about very often. So huge thanks to the Honourable Lady for making sure that we are, because I think it is definitely something we need to do more often. We've heard from others how prevalent this condition is, but we still fall so far short in addressing and the stigmatising nature of it. It's just a headache. We've heard others say this. I mean, it's easy to knock past. And I was very lucky, I suppose, that in one of my earliest jobs, the boss I worked for, they themselves suffered from migraine, so there was a level of understanding there. But that's just fortunate circumstance, and we need to have a much, much clearer opportunity for anyone suffering from this condition. I think there has definitely been improvement, albeit in certainly Scotland, England and Wales, the time waiting for treatment is lengthening from the figures put out by the Migraine Trust. So we all need to be doing better in that sense, but certainly Scottish Government is supporting a very high standard in migraine care, with 86% of health boards giving access to the CGRP blockers, which is welcome, but we can't rest until that's 100%, and that's 100% everywhere. We certainly can't be complacent. And we know that migraine attacks can signify impact in all aspects of anyone's life, as we have heard. And there is so much more we could do. We've heard CGRP blockers are obviously one medication. There are others, and I personally done some work looking into the potential for alternatives like psilocybin, which we have had some debates in this place previously about. And I think it was last June or thereabouts, met with Professor Joe Neal at the University of Manchester, who was highlighting some of the challenges that they face simply in trying to research the potential for psilocybin. It's still classed as a Schedule 1 drug like crack cocaine or heroin. So the blocks that are in place to simply researching what is possible are a massive hurdle to actually moving forward what could be a very significant, useful treatment for many people. Because as we've heard, not all treatments work for all people, and everybody will have their own thing that works best for them. There is a vast body of research that does exist, but again, so much more could be done. So I would ask the government to, again, consider what more it could do to perhaps consider those blocks to research, particularly, to make that slightly more straightforward so that we can actually all have a much better understanding of what is possible. But there are glimmers of hope, and the Centre for Sustainable Delivery has published a national pathway for headache care, which will help to further drive standards in migraine care across the NHS in Scotland, certainly. And the SNP would continue to push the UK Government on the right for flexible working. Now, while there is now the right to request flexible working in legislation, we think that actually should be a right, not simply a request. A Migraine Trust report called Heading in the Wrong Direction said there should be greater awareness of the pathways that exist for managing migraines, and the study revealed that half of Scottish health boards have said that they had undertaken work to review their headache and migraine pathways. So again, encouraging, but half's only a half, and it's still not enough. Scotland was found to have the best access to medication, as I've mentioned. However, more still needs to be done. The Migraine Trust report said there are fewer than 80 GPs specialising in migraine and headaches in the UK. I mean, that's just simply not enough. You're very lucky if you find one who has that understanding. But, I mean, when you're talking about universal health care, 80 GPs across the whole isles of the UK is not close to enough. And Robert Music, the Chief Executive of the Migraine Trust, said not only are patients struggling, but poor management of migraines putting unnecessary additional strain on the already struggling NHS. We're seeing rising A&E admissions for migraine across the UK. He went on saying, there's a shortage of GPs, consultants and nurses specialising in headache to meet the need that we know exists, and a broad lack of understanding of the condition, meaning patients are not being treated in the right place or even at the right time, if at all. Now, this just simply isn't good enough for any of us, and we need to be pushing, and I hope debates like today help to do that, to just raise that awareness, to say this is a very serious condition that people have, that we need to be doing so much more. And Dr Brendan Davies, the chairman of the British Association for the Study of Headache and consultant neurologist at Royal Stoke University Hospital, said migraine is the most common of all neurological disorders, yet is vastly under-recognised. The time has come for a nationally agreed educational framework and quality standard for primary care, as we have with other important long-term conditions. Now, as I and my party persistently advocate for enhancing devolved powers, that will be no surprise to anyone in here. We would like to see more devolvement of certainly employment powers, so that we could move forward some of the issues I've previously mentioned on employment and flexible working options. I think that is something that, while not addressing treatment, would help at least individuals to manage condition as it applies to them, and finding a way that best works for them, in the way that we all look to try and manage the best treatments that we can identify. If we could manage the work around that, I think that would be beneficial, not just to the individuals, but also to the economy. And with each passing day, the government needs to neglects to use the reserve powers to address workplace changes. It underscores the need for us to have the ability to make these decisions in Scotland. Now, I hope I'm going to hear some positive from the Minister. I think everyone in here is coming from the same place and saying we recognise that there is a great deal that has been done, but there is significantly more that can be done. And I think it's on all of us to embrace that and take forward that challenge. But I look forward to hearing the Minister's response as to what steps that we could potentially take initially, immediately, and then longer term. And just once again, commend the Honourable Lady in bringing the debate today.
Shadow Minister Karen Smith.
Thank you, Mr Mundell. It's a pleasure to serve under your chairmanship. And I do want to start by thanking the Honourable Member for Bishop Auckland for opening the debate and sharing her own very personal experience. I think that's very powerful for other people, particularly to hear that, and how the condition has affected her. And we've heard some fantastic contributions today. We know that 1 in 7 people in the UK are living with migraine, with women being disproportionately affected. And I agree with the chair of the Women Equality Select Committee that does need to be addressed. Women are underrepresented in research and development more generally, and we need to understand why this is the case beyond reproductive issues in the women's health strategy. And migraine attacks can be hugely debilitating and can last between 4 and 72 hours and longer, often causing pain, vomiting and dizziness. And again, we've heard from the member for Romsey in Southampton North about the impact on children, and I think very movingly from the other member for South Staffordshire about the impact, the all-consuming impact on family life, every part of our lives, social life, education and employment, yet often misunderstood and underdiagnosed. Migraines affecting people's ability to access full employment, with 29% of those who suffer reporting they've had to move from a full-time to a part-time work, and a further 25% having left a job altogether. And I think people listening to this debate, from people they might think are in control of their careers and at dispatch boxes, etc., will find that very powerful today to understand that they are not alone. This adds to the number of people who are economically inactive because of long-term sickness, which has risen to over 2.5 million, an increase of more than 400,000 since the start of the pandemic. And that has a huge impact on our economy, as well as on individuals' health, well-being and ability to support themselves and their families. And I am deeply concerned that the measures laid out by the government to tackle the leading health-related causes of economic inactivity are not ambitious enough. I'm joining the former Chief Whip in exhorting the government into greater action and more government indeed, because the Access to Work scheme faces huge backlogs. So we do want to hear from the Minister today what the government can do, what it is trying to do to support those suffering from debilitating migraines, and how we can help them access work. Furthermore, support from employers is vital to everyone living with chronic migraines, and we've heard debate again about whether this should be considered a disability, but even people who are reported as disabled report that disability-confident employers do not report much better experiences to those working for employers who are not members of the scheme. So I think we do need more action from the government to ensure that disabled people and those with long-term conditions, such as chronic migraine, can access the support they need at work. As with too many medical conditions, waiting lists are long. Once diagnosed, it can take up to 29 weeks to access a neurologist or a headache specialist. 14 years of government mismanagement has left our NHS unable to deliver a full and comprehensive range of health services, and this is impacting on care and treatment for migraines. That's why Labour will build an NHS fit for the future, providing it with the staff, technology, resources and reform it needs to improve patient care, cutting waiting lists and ensuring timely diagnosis and treatment for the millions of people affected by migraine by getting the NHS working around the clock, giving staff the opportunity to earn more for weekends and evening shifts, and getting local hospitals working together will mean that the NHS can deliver those extra 2 million operations, scans and appointments a year. So, what measures will the Minister take to tackle those waiting lists, and particularly the services around neurology? We've heard today how new treatments can give hope to those suffering from migraines, and CGRP antibody medicines have been approved by NICE to prevent migraine in adults. However, as we've heard, only 52% are offered it, with a long route to take before being eligible. The National Institute for Health and Care Excellence, NICE, last updated their guidance in 2021, and we'd be interested to hear from the Minister if he's having further discussions with them about wider access. This is a condition which can be isolating and debilitating. And we know that pressures on mental health services are acute, but with 78% of respondents to the Migraine Trust survey saying it impacts their mental health and 65% reported experience anxiety as a result of it, it's vital that we consider the mental health impacts of living with a migraine. So I obviously am keen to see our proposals in the Labour Party for a whole government strategy to improve mental health outcomes and make early interventions a reality for people. That's why the next Labour government would implement an ambitious plan to cut waiting lists by recruiting over 8,500 more mental health staff, providing access to mental health support in every school and delivering an open access mental health hub for children and young people in every community, which would help with some of what we've heard today about young people and children understanding the debilitating effects of this illness. Finally, further research is really important, as we still don't fully understand what causes migraine, and I think the SNP spokesman spoke very eloquently about the need for that. We would support our research community with a new regulatory innovation office, which would make Britain the best place in the world to innovate by speeding up decisions and providing clear direction based on a modern industrial strategy. The new office would help improve outcomes for those living with migraine, tackling the NHS backlog by accelerating the approval for clinical trials, which have fallen off a cliff under this government, and delivering better access for patients to the latest treatments. Those living with migraine should be able to access care when and where they need it. And the next Labour government will ensure that we have the staff resources needed to improve waiting lists, the research environment which would cultivate access to new treatments.
Minister.
Thank you, Mr Mundell. It's a pleasure to serve under your chairmanship. And can I start by thanking my honourable friend, the member for Bishop Auckland, for bringing this very important debate to the House today. I know that she has long been a champion for those living with migraine, and that her ongoing struggle with chronic migraine, as she talked about, made it difficult, if not impossible, some days to keep up with the demands of her ministerial role. Since leaving that role, she has continued to shine a light on the impact of migraine at work and what it means to live with migraine. I'd also like to pay tribute to the outstanding charities that support the around 10 million people living with migraine in the UK. I know, for example, that Migraine Trust does fantastic work in empowering, informing and supporting patients and driving improvements in treatment and care. I'd also like to thank my right honourable friends, the member for South Staffordshire, my right honourable friend, the member for Romsey and Southampton North, my honourable friend, the member for Kettering, and the members for South Antrim, East Londonderry, Londonderry, Midlothian, Greenwich and Woolwich and Bristol South for their contributions. Almost all in their contributions talked about the stigma around migraine, with many setting out their own personal experiences. And we all know that awareness is key to addressing discrimination, so I very much welcome each and every contribution to this debate today. Migraine is one of the most common neurological conditions, affecting an estimated 10 million people in the UK, and yet we very rarely speak about it and its impact in this House. Many of us have first-hand experience of migraine, or at least some insight into the enormously debilitating effect it can have on people living with the condition. Indeed, my own sister, Andrea Stevenson, who I know you know, Mr Mundell, and many other members may know, suffers from migraine, and I've seen the impact it's had on her over the years. As we've heard this morning, migraine is a severe and painful long-term health condition. And as my honourable friend so eloquently said, it is so much more than just a really bad headache. Anyone who lives with migraine knows it can have a very significant and negative impact on quality of life. Perhaps the cruelest aspect of the condition is its ability to strike with little or no warning, disrupting people's ability to perform even the most basic daily tasks. Migraine symptoms can last for days, affecting all aspects of life, including family life, work life, and the ability to engage in social activities. Even between attacks, migraine can impact quality of life, especially when people try to limit daily activities to prevent another migraine. And although the human cost is important and the most important factor, it is worth reflecting on the economic cost, which my honourable friend and the Right Honourable Member for South Staffordshire set out so well in their speeches. This is why timely access to appropriate and effective care and treatments is so important. Accurate and timely diagnosis can ensure that people can access migraine treatments as early as possible, helping them to get the care they need to treat attacks when they strike and help prevent future ones. There's no specific test to diagnose migraines. For an accurate diagnosis, GPs must identify a pattern of recurring headaches along with the other associated symptoms. Migraines can be unpredictable, sometimes occurring without the other symptoms normally associated with the condition. Obtaining an accurate diagnosis can therefore take some time. The National Institute for Health and Care Excellence, NICE, guidelines, headaches, diagnosis and management of headaches in young people and adults, updated last in December 2021, set out best practice for healthcare professionals in the care, treatment and support of people who suffer from headaches, including migraine. It aims to improve the recognition and management of headaches and migraine, with more targeted treatments to improve the quality of life for people with headaches and to reduce unnecessary investigations. NICE has also produced a clinical knowledge summary on migraine. Clinical knowledge summaries are concise, accessible summaries of the current evidence for primary care professionals, focusing on the most common and significant presentations in primary care. They give trusted information to support safe decision-making and improve standards of patient care. The usual treatment approaches to migraine are designed to either stop or prevent attacks. Treatment for acute migraine includes medications such as anulgics and triptans and antiemetic. Treatments to stop or reduce the frequency of migraine attacks include medications such as beta blockers, tricyclic antidepressants, and anti-epileptics. We are committed to supporting timely and consistent access to new, effective medicines for NHS patients. And so I'm pleased that in October last year, NICE published technology appraisal guidance recommending rimegepant for acute treatment of migraine. Rimegepant is recommended where patients have tried at least 2 triptans, but they didn't work well enough, or where patients cannot take triptans, or where they weren't tolerated, or other medication has been tried but didn't work well enough. In separate guidance, NICE also recommended last year that rimegepant as an option for preventing episodic migraine in adults where at least 3 previous preventative treatments have failed, opening the way for up to 145,000 people in England to choose that option. Yeah.
Thank the Minister for giving way. I just wondered, and very appreciative of him setting out all that's been done. I just wondered, one of the things that sort of was touched upon by a few of us was just on the CGRP blockers. Now, I'm sure there's maybe an exciting announcement or something like that coming, but if there isn't maybe an exciting announcement, can you maybe give us sort of reassurance that this is something that could be looked at to make sure that something maybe could come out of this in terms of being done?
My right honourable friend anticipated my next point. Several honourable members in the debate today have mentioned the difficulties some patients have experienced in accessing CGRP blockers, and this was an issue that the member for East Londonderry raised in his intervention. And I note my right honourable friend's concern and my honourable friend's comments about the NICE guidelines should be reviewed to allow specialist treatments like CGRP blockers to be available as a first-line therapy. NICE develops its recommendations independently, based on assessment of the available evidence of clinical and cost effectiveness and through extensive engagement with interested parties. It is right that these decisions are taken independently on the basis of the available evidence, and it would not be appropriate for me, therefore, to directly intervene. However, NICE keeps its recommendations under active surveillance, and if significant new evidence were to emerge, NICE would review its guidance. So I very much hope that they have been listening to what's been said by honourable and right honourable members in today's debate and look at the emerging evidence coming from the various charities involved, such as the Migraine Trust, that might prompt them to review their guidance. The NHS in England is legally required to make funding available for treatments that have then been recommended by NICE. If there are any concerns about the availability of a NICE recommended treatment in a particular area, it is important that honourable and right honourable members raise that with the local integrated care board in the first instance, but I'll be more than happy to look into situations where members still have concerns. On the issue of CGRPs and prescribing rights in primary care that my honourable friend raised, I think it is an interesting point. I have asked the MRHA to look into this matter, and I will write to my honourable friend in the coming days. Similarly, I will take away the point made by my right honourable friend, the member for South Staffordshire, about what more we can do to better utilise our local pharmacies. My right honourable friend and ministerial colleague, the member for South Northamptonshire, is responsible for pharmacy policy, and she's already overseen the rollout of Pharmacy First, ensuring more conditions than ever before can be addressed by pharmacists rather than people having to wait to go direct to see a GP. We would expect that patients suffering from migraine would normally be treated at the moment first by their GP. If this fails to resolve the problem, then patients will be referred to a consultant neurologist for further investigations and tests. We recognise that challenges within secondary care in terms of waiting list size and the length of wait, with patients waiting far too long to access the specialist care they need. Neurology is particularly challenging at the moment, with a need for more neurologists, more specialist nurses and allied health professionals. We are committed to reducing waiting lists. And to this end, we commissioned NHS England to develop a long-term plan for the NHS workforce for the next 15 years, which was published in June 2023. This sets out how we will deliver the doctors, nurses and other professionals that will be needed, also taking into account improvements in retention and productivity. The plan looks at the mix and number of staff required and has set out the actions and reform across the NHS that are needed to reduce the supply gap and improve retention. The plan will help ensure that we have the right numbers of staff with the right skills to transform and deliver high-quality services fit for the future. And my honourable friend, the member for Bishop Auckland, the member for Greenwich and Woolwich, and the member for the right honourable friend, the member for South Staffordshire, all raised the issue of awareness amongst GPs. UK medical schools determine the content of their own curricula. The delivery of these undergraduate criteria have to meet standards set by the General Medical Council. The standards require the curriculum to be formed in a way that allows all medical students to meet the GMC's outcome for graduates by the time they complete their medical degree, which describes the knowledge, skills and behaviours they have to show as newly registered doctors. Therefore, whilst not all curricula will necessarily highlight specific conditions, they all nevertheless emphasise the skills and approaches a healthcare practitioner must develop in order to ensure accurate and timely diagnoses and treatment plans for patients, including for migraine. And all healthcare professionals, including GPs, are responsible for ensuring that their own clinical knowledge remains up to date and for identifying learning needs as part of their continuing professional development. The Royal College of General Practitioners has developed e-learning resources to update primary care clinicians on the nature of migraine, the different diagnoses and how to approach a patient with headache. Through the NHS England's Getting It Right First Time GIRFT programme, we are also offering practical solutions for managing the demand for services within secondary care. There have been major advances in treating neurological conditions, including migraine, but services often struggle to keep pace with innovation, which has a significant impact on the outcomes for people living with these conditions. GIRFT is a national programme which is designed to improve the treatment and care of patients through in-depth clinically led review of specialties to examine how they are currently being done and how they could be improved. The GIRFT National Specialty Report on Neurology, published in September 2021, makes a number of recommendations applicable to migraine. For example, the report highlights that providing support and advice to GPs in diagnosing and managing patients with headache can improve management of patients without a patient necessarily having to be seen as an outpatient. GP access to CT and MRI imaging would also enhance the ability of GPs to manage headaches in the community using appropriate guidelines. As several honourable and right honourable members have also said, research is key. Investing in research is also a key component of supporting people living with migraine. It plays a vital role in providing those working in the NHS with the evidence they need to better support patients and support access to pioneering treatments, diagnostics and services. The Department of Health and Social Care funds research through the National Institute for Health Research, the NIHR. The NIHR has funded and supported a range of research projects on migraine over the past 5 years. This has included studies to assess the efficacy and cost-effectiveness of drugs to prevent and treat migraines, as well as resources and training on self-management. For example, a study which is close to completion is looking at the comparative clinical and cost-effectiveness of pharmacological treatments for adults with chronic migraine. In drawing my remarks to a close, Mr Mundell, I want to once again thank honourable and right honourable members for their insightful points made during today's debate. I hope that they and my honourable friend are reassured by some of the measures that I have outlined today. I do recognise that we must go further, and I can assure them that I will continue to support people living with migraine through system transformation, through NIHR research, and through exploring and investing in new treatments to ensure that we're delivering real results for patients on the ground. Thank you.
Dehenna Davison to wind up the debate.
I'm very grateful to the Minister for his remarks, and particularly for the fact that he's actually already actioned some of our points here by asking the NRHA to look into primary care prescribing, and also the fact that his ministerial colleague is also potentially exploring further use of pharmacies, which clearly is a really positive step forward. They go back to a brilliant comment made by my right honourable friend from South Staffordshire, which is clearly we need to tackle migraine in a different way. And so I hope there can be a little bit more oomph from the department when it comes to recommendations from NICE. Now, I appreciate independence is crucially important, but through raising awareness as we are doing here today, and hopefully through some input from the Minister too, whilst not asking NICE specifically what to put into their guidance, perhaps asking for another review is something that could still be achieved. Now, I'm very grateful to all honourable and right honourable friends who've attended here today and made some very, very interesting points, and actually raised some individual cases of constituents who are living with this horrible condition. Now, my right honourable friend from South Staffordshire talks about the wider impact of migraine, something many of us have touched on today. And I think, again, that's just one point I really want to raise, is that this is not just a health condition that comes on every so often. It's the wider impacts on your life, it's the anxiety, it's the in-between days when you're wondering when an attack might next strike, something I know that was also referenced by the Minister, and I'm grateful to him for recognising that, and also talking about his own family's experience of migraine, given his sister also suffers from the condition. Very grateful, of course, to my honourable friends from Romsey, right honourable friend from Romsey and Southampton North. Excellent, I get it right eventually. And my honourable friend from Midlothian for sharing their own experiences of migraine, though different experiences in some ways, very similar in others, in terms of the severity of attacks and the sort of anxiety in how to tackle those attacks. I was absolutely staggered by the amount that my right honourable friend has spent on tackling her own migraine. And doesn't it say an awful lot that we know Botox for some people can be an incredibly effective treatment, and yet so many are unable to access it on the NHS despite it being an approved treatment? Another one of those lifelines that I think we do really need to address. Now, she raised the case of Monica, her own constituent, and the issues that she's had with her employer, and I would completely agree with her and my honourable friend from Midlothian that it is absolutely right that migraine should be considered a disability formally, so that reasonable adjustments not only should be put in place by employers, but then have to be put in place by employers because of the disability status of this condition. And I know my honourable friend, the member from, I'm going to get this one right, East London, Derry, South Antrim. I've got my DUP colleagues confused. I can only apologise, but it's because they both share brilliant passion for Northern Ireland and brilliant passion for tackling the issue of migraine. For raising the point around DWP assessments and the difficulty people have in actually accessing support when, unfortunately, they're out of work as a result of chronic migraine. And, of course, we've heard the statistics of how many people do, unfortunately, have to give up work as a result of this disease. So hopefully we can take that one up with DWP next time to really hope that they can review their processes. But certainly, having chronic migraine listed as a formal disability would be a positive step in helping ensure that that is done. Now, my honourable friend from South Antrim also discussed the point around the devolved bodies. And of course, we heard some great testimonies from the SNP spokesperson from Midlothian about the positive steps that are being taken place in Scotland, particularly looking at the number of Scottish trusts that actually allow CGRP blockers to be prescribed. But it's still not 100%, as he rightly said, and we do need to go further to make sure that new innovative treatment options that can work for so many people can be accessed by all of those people who are struggling. Now, I'm very grateful also to the Shadow Minister for not only responding today, but actually getting in touch with me in advance of the debate today, so that we could sort of share a few notes about just the impacts that chronic migraine really can have. And she's right, of course, to raise the impact on children, something that I didn't particularly cover in my speech, but something that my right honourable friend from Romsey in Southampton North touched upon, given that she started experiencing migraine at such a young age. For children, in some ways, it's even more terrifying because there's that lack of awareness of what is happening to you when a migraine attack strikes. So again, one example of how we absolutely need to get this right to give people that better quality of life. Now, of course, she also talked about long-term workplace inactivity. And the best way that, frankly, we can tackle this is by getting people earlier diagnosis, earlier treatment, and earlier treatment that actually works. Now, part of that, as we've talked about, comes down to knowledge. And I'm grateful to the Minister for talking about the way in which medical training is actually sort of outlined and is done. And it's great to hear that there are e-learning modules available for GPs and other medical practitioners to access, specifically on headache and migraine. But I say we need to be bolder. I say we need to go further. So I think off the back of this, I'll be contacting some of those medical bodies myself to ensure that they know just how debilitating and difficult migraine can be, in the hope that they can make sure that their educational modules not only are top-notch in delivering the right information to the right people, but also they're making sure people are taking those modules. They're not an optional extra, they're an absolute necessity. I've probably missed some bits. Yes, I have. On the knowledge point, I'm very grateful to my honourable friend from Greenwich and Woolwich, who is no longer in his place, but raised that point around knowledge, and particularly knowledge around hormonal migraine, something that I know many people do experience. And so it's absolutely right that we continue to research that, but also make sure that medical practitioners have the knowledge that they need. And of course, my honourable friend from Kettering also raised the experience of his constituent, which again, another human story that tells the tale of chronic migraine, another human story that tells the tale of just how difficult this blooming thing can be. And I'm really grateful to all members here today for taking part in this debate, for getting involved, and for showing that, you know, there are people here in Parliament who care. So to people watching at home, we're here, we hear you. We're going to do all we can to make this better. And I'm going to keep nagging the Minister until we really see improvements in migraine care.
The question is that this House has considered access to migraine treatment. As many as are of that opinion say aye. Aye. Of the contrary, no. I think the ayes have it. The ayes have it. Order, order. This sitting is suspended until 11 a.m.